Thank you, LIDC, for inviting me to e-present on this very important non-coronavirus health topic today. For those sitting at home, self-isolating and wearing your glasses, can you imagine a day without them? If you are as short-sighted as me, you really understand the struggle. Without my glasses, I'm actually legally blind and disabled. I can't even recognize someone sitting more than an arm's length away from me. Luckily for me, my vision can be corrected through glasses, something which I really want to highlight today is actually possible for so many people around the world whose vision is impaired, and they just don't have the right access to these services. A bit about me. So I'm an optometrist by background, and I've worked for over 5 years with a healthcare charity in India. And I really want to use this example as a way to talk about the challenges of global vision impairment, and also what I wanted to do is talk about how vision impairment relates to international development and the Sustainable Development Goals. First of all, let's think about this for a second. 30% of the world can't see properly. That's pretty staggering, isn't it? According to WHO's World Report on Vision, which was released late last year, 2.2 billion people worldwide have vision impairment. Out of which, 1 billion, which is almost half, could be prevented or is not yet addressed. Now, this not yet addressed part I wanted to emphasize because this is something that I wanted to talk about in more depth during this presentation, and which really is the scary part. Another thing to mention in this report that WHO released was that there's going to be large demands in eye care in the next 50 years due to the aging population, and that's something that was really highlighted in this report. If you see on the right here, China and India together account for 45% of visual impairment. And yes, they do also account for 37% of the global population, but you can just see where the real burden lies. The project that I undertook was also based in India, which is why I wanted to just highlight this for a second. So for those who are not in the eye care world, I wanted to briefly talk about the difference between blindness and vision impairment. Vision impairment is a term that's often defined slightly differently clinically and epidemiologically. WHO defines vision impairment more broadly when an eye condition affects the visual system and one or more of its visual functions. Most epidemiological studies talk about vision impairment in the way that it's shown on this table here. So what does vision worse than 612 actually mean? It means the person who sees 612 can see something at 6 meters when a normally sighted person can see that same thing at 12 meters. To give you an idea, 612 is usually the legal driving limit in most countries. Blindness is actually when visual acuity is worse than 360, which means that what this person can see at 3 meters is really what a normally sighted person can see at 60 meters. Another thing to also consider with vision impairment, it's not just to do with your central vision. If you have a visual field constriction, which is the inability to see off the side of your eye, of less than 20 or 10 degrees, it's also considered severe visual impairment or blindness. So, as you can see here, the highest cause of global visual impairment is actually URE. You can see here on the graph that big pink section represents URE. So what is URE? URE is uncorrected refractive error, and it accounts for almost 50% of global vision impairment. And this is probably what makes up most of that 1 billion of the to be addressed that WHO talked about in the World Report of Vision. This is, and refractive error is actually the need for corrective spectacles or contact lens prescriptions. Yes, you heard right. This is the number of people that actually need glasses or contact lenses. After this, cataract follows at 26% of the cause of visual impairment globally. So this does seem a bit unusual. Why is there so many people in the world unable to see because of lack of spectacles? Compared to other more difficult to treat eye conditions or even health conditions like HIV, this should be far more simpler to fix. And yet, there are so many different barriers affecting uncorrected refractive error, which are some similar to most health problems around the world, especially in low middle income countries, but some are actually very unique to eye care. But before we go into those barriers, I wanted to talk about bringing it back out of eye care for a second and talk about how vision impairment really fits into the discussion around international development. And and especially in regards to the SDGs, the Sustainable Development Goals. Starting with SDG number 3, which is to ensure healthy lives and promote well-being for all at all ages. Those of you who are familiar with SDG 3, the dialogue around that is to do with the universal health coverage. And it's the capacity to provide health services to those who need it, the services that they need, and without financial hardship. And one of those essential services is in fact eye care. So it needs to be considered in order to achieve UHC by countries. If we break this down a little bit further, SDG really calls for the need for quality services and better access to them. And in general, eye care service suffers from both of these issues, access and quality in low and middle income countries around the world. This is something that I want to talk about a little bit more about my case study where we, with our charity, really did try to tackle SDG 3 head on by training optometrists to improve the quality of eye care and also increase outreach, making services closer to home and therefore improving access. So going on to the second one I've highlighted here, which is SDG 10, which is to reduce inequality within and among countries. Addressing vision impairment is important to achieving SDG 10 as it helps to reduce inequality. Poor vision can result in increased inequalities due to basically people's inability to work, study, or seek help. Poor vision, like other disabilities, also exemplifies underlying social inequalities that already exist, such as race, gender, and poverty. And so, in my opinion, vision impairment is actually kind of like a hidden disability. It is often overseen because of its lack of visible impact and often considerably simple solution. And eye programs that address vision impairment can actually reduce those suffering from treatable vision impairment. What that does, in fact, is it improves inclusion and it allows them to, seek out better opportunities for themselves, like employment and education. And in terms of those who are irreversibly blind, the way to target this SDG goal is also to, provide rehabilitation services like low vision services in eye care. And this will improve the living standards, improve some level of independence for these people, and also therefore reduce inequalities. SDG number 8. Now, this one is an interesting one because this is to do with more sustainable economic growth and what they call inclusive economic growth. And in terms of vision impairment, one way to think about it is that having poor vision actually really restricts full and productive employment. Poor vision, like I mentioned before, results in poor learning in childhood, which then follows through to poor employment prospects in adult life, reducing the contribution to the workforce. Age-related vision loss, which is like, a lot of you might be, wearing reading glasses for the moment or have had cataract surgery. This actually like basically short ends people's employment prospects, and people have, sort of stop working after 40 because they're not able to do their general tasks, which are very much something solvable with the proper treatment in eye care. There's actually many economic studies that show the effect of visual impairment on country GDP. Some suggest that vision impairment results in up to $168 billion loss of productivity globally every year. There was a special study called the Invest in Vision study that shows the additional income that would be earned as a result of building sustainable eye health systems and actually treating the backlog of vision impairment and blindness would considerably outweigh the costs by a factor of 1 to 4 in many developing countries. And secondly, in terms of SDG 8, number 8.5 talks about the importance of achieving full and productive employment and decent work, including those with disabilities. And therefore, including economic growth implies employment should be inclusive with those who are also visually impaired. So there's so many, back and forth ways that vision impairment is really quite fundamentally intertwined in achieving the SDGs. There, now I just want to talk about the main barriers to eye care, and I think there's some interesting elements of eye care that make these challenges particularly unique to eye care, and some are quite overlapping with other, healthcare challenges in other fields around the world as well. And one of them is awareness and acceptance. So this one I feel is kind of unique because vision impairment in general and eye disease in a lot of ways don't actually cause pain. And it's well known that people seek health care when in fact something hurts. So the problem in eye care in the sense is that most conditions actually don't. Secondly, most people have two eyes, which means that poor vision in one eye often gets really unnoticed for a longer period of time. In terms of refractive error as well, I wonder whether the simplicity of vision correction actually acts like a barrier to eye care. It almost like it devalues the importance of the problem, whereas treating an eye disease like cataract is far more better advocated for around the world. And the last thing about awareness is that many people in lower middle income countries, in rural populations, feel that vision impairments is actually just a natural part of getting older. And that's why that often causes poor health, health seeking behavior as well. In terms of acceptance, this is also kind of unique in the sense that spectacle wear is often seen as a cosmetic issue, especially in women in many cultures around the world, as it may identify as looking like you have a disability, and it can sometimes even affect women's prospects in getting married. Some people, and this happens not just in low and middle income countries, but even where I practice in Australia, was that every third day or so I'd get asked or questioned whether the glasses that I'm prescribing are going to make my vision worse. So I think there is a little bit of a mistrust in the profession, and local remedies for eye care are often what are chosen over and above, professional care. Another point is about the access and affordability. And this is an issue that I think many health services face in low and middle income countries. The unique aspect of this in eye care, I feel, is that because eye care is often not directly integrated into health services, people have to sort of seek out eye care specifically. So they may have to, take time off work and often take a, elderly parent, or travel a long distance, which the travel costs also add up. So even if the actual care itself is free or of low cost, just getting there and organizing the logistics often seem like a bit too much effort. Now, in terms of, so those are more like the patient side factors, but also in terms of the system side factors that act as barriers to care. One, I think, is something that really was highlighted in the World Report on Vision, is about the need for integration and data. Eye care so far in history so far has really operated in silos, which has resulted in the dominance of what we call like top-down vertical programs that have been really good for eliminating things like trachoma, for example, but have also can often be unsustainable and damaging to existing health systems. A personal example of this was when I recently went to Kenya as part of a different sort of research, and local eye health workers were expressing concerns as a large international NGO had just come through the eye health facility and depleted a lot of their local resources in the ophthalmology department, making it hard for them to sort of advocate for more supplies after they left. So sometimes, these sorts of mechanisms can actually make things worse. And poor integration of eye care into health services, like I mentioned in the previous point, restricts access. So people sort of have to seek out eye care separately, making it difficult to actually obtain eye care. And for this reason, I think people have, there's a lot of dialogue around this about health system strengthening, and it's considered an important mechanism to reduce reliance on these types of vertical programs in global health, because basically they put the power back in local ministries of health by creating better local health information systems to improve decision making. And one of these things which eye care doesn't have, which other areas of health have, is like monitoring indicators. Like I'm sure many people might have heard of like under five mortality monitoring or immunization rate monitoring. It's done quite well in most low and middle income countries, whereas eye health does not have these kind of national indicators, and they rely on more like your surveys, which are called rapid assessment of avoidable blindness (RABs). These have been really effective in estimating global burdens of disease, but in terms of planning for services, I think there's need for better data collecting mechanisms. And finally, the other barrier that I wanted to talk about, which is more related to my eye care project, which I will get to in a second, is about human resources. And this is again something that health services in general, health systems in general, around the world struggle with. But remember how I spoke at the beginning about uncorrected refractive error being the leading cause of vision impairment? This could also be due to lack of adequate training in deriving the correct prescription, spectacle prescription. Firstly, there's a lack of numbers in terms of the skilled professionals in eye care. And in terms of the number of what they do is they try and calculate the number of ophthalmologists per million. And a study reveals that the number of ophthalmologists per million in low income countries averaged about 3.7 opthals per million, whereas a mean of 76.2 was found in high income countries. So that is an 18-fold difference in terms of the difference between low income countries and high income countries in terms of the availability of specialized ophthalmologists. Optometrists, which is where I come in, are one other eye health professional that can actually help fill the gap of ophthalmologists in correcting refractive error and treating common eye conditions. However, generally outside of ophthalmology, eye health professions are not as well regulated across the world. Like in the UK or in Australia, you have to register. You're a registered health practitioner, but in most other countries, optometry is still really not completely recognized. And I want to explore this in a little bit more detail when I talk about my eye care program that I developed. But human resources in eye health can actually be structured in ways to make up for these inadequate numbers of ophthalmologists. And one example can be seen by looking at this pyramid on the screen. This is called the LV Prasad eye care model, eye health vision pyramid, which is a special sort of system that was developed by LV Prasad in India, where they have vision guardians. If you see the very bottom of this pyramid, vision guardians and vision centers, and these are allied health professionals or technicians that are located in rural locations in India. So they're right at the doorstep of the communities. Then how it works is that there's strict criteria and referral guidelines for them to refer up to the next level, so to service centers, tertiary care centers, and then specialized centers, which are usually located in the city, in the main sort of cities. And this works if there's really good training and there's good referral pathways that are set up, which are really strict and functioning. And so the main issue is that not all the time that we can actually get to this level of perfection. But it's just a nice kind of way to show that there are ways to get around the human resources issue. So this brings me to the next point about now more towards what we spoke about at the beginning, which is the organization that I work for is called Australian South Asian Healthcare Association, ASHA, and it's aimed at delivering healthcare programs across South Asia. The name of the organization, like I said, is Australian South Asian Healthcare Association. So we do projects in various countries, including India, Sri Lanka, Cambodia, a few others. I've been the eyecare coordinator for this charity and pretty much been involved since its inauguration in 2013. And eyecare is just one of its domains. As you can see here, there's also other programs such as maternal and child health and non-communicable disease. And the whole model that ASHA is based on is that it uses education to improve health. So it is a grassroots organization in the sense that it's funded very locally, and it relies on volunteers, mostly healthcare professionals, to volunteer their time to be involved in these programs. You may know about Bhopal, which is where we conduct our eye care program at the moment, and it's kind of known around the world in a very unfortunate way because of the gas tragedy that occurred in 1984. The city has suffered sort of ongoing health and economic effects from that incident. And when we actually visited Bhopal first in 2015, and our first project, what we did there was more of a typical outreach camp to provide eye health examinations for children in slum communities. But the way we kind of got to that is that we collaborated with the local trust fund based hospital called Seva Sadan Eye Hospital. And as part of our week there, we actually visited the hospital, and we we actually had a few observations when we were there. It was interesting because there was actually quite an impressive amount of technology available. So it was, even though it was a trust fund hospital, mostly serving impoverished communities, um, they actually had even like the latest technology in OCTs and visual field testing. And it was also really interesting that they'd already started setting up those rural vision centers, which I spoke about previously in that pyramid model. So they seem to have the right idea in terms of how to improve their outreach to communities and how to provide patient quality care. And it's interesting because in India there is that something I've noticed is that some hospitals such as these have the funding to set up these sorts of things. The main issue that we found, and which is why we decided to get involved, was that there was a high level of variability in the skills of optometrists at the hospital. So 40% on average had a 4-year bachelor's degree, which is more commonplace in high income countries as well, whilst 60% had a 2-year diploma. And this was basically causing a few problems. It was limiting the confidence of optometrists in undertaking outreach, as this would require them, practicing away from ophthalmologists, away from the hospital. Um, and optometrists were also meant to manage, what we call refraction, which is the technique used to derive your spectacle prescription. And also, they're also meant to screen and manage some basic eye conditions. But because this wasn't being done well enough, it was resulting in a bottleneck effect to ophthalmology, where patients were, when we were there, patients would come in the morning and were waiting more than a day to, on long queues to see the doctor. And this resulted in ophthalmologists feeling quite overworked, and they felt like they couldn't focus on the complex cases that required their attention. And finally, the effect of all this was it was reducing the quality of care, as optometrists were often not able to do like refractions correctly or perform or know when to perform specialist techniques. Variability in skill levels meant that some optometrists were well skilled and were often quite likened to the ophthalmologists. So these, special optoms became glorified technicians for their ophthalms to manage their patients. And so what happened is that they took these optoms away from their normal clinical duties in like performing refraction or screening, and then the more poorly skilled optometrists were required to do that. And then what would happen in effect of that would be that these poorly skilled optometrists would do poor, refractions, and which would result in remakes of glasses, and the ophthalmologist would then have to step in, and this then decreased the trust in the ophthalms of the optometrist. And so this sort of cycle seemed to continue, and this is really why we wanted to intervene. So based on these observations, we selected key topics, and one of them being refraction, which we've already spoken about, being really the bread and butter of optometry to deliver the right spectacle prescription. And also we also added in topics like history, taking a history, screening, and binocular vision, which is a technique used to test for mostly children and young adults. What I made sure of is I really wanted to make sure the quality of the material that we're teaching. So we collaborated with Deakin University in Australia to design the education program. The program has been running for over 5 years now, and there have been annual 1-week programs where I've recruited Australian optometrists to volunteer and travel to Bhopal to deliver the topic at the time. And the way we do it is through interactive lectures and workshops. And we also run something that I'm quite proud of called active observation, where we actually, after doing the training, we actually go in and sit with them during the normal, clinical rotations, and we watch them perform techniques with patients in the hospital. And just to show you, these are some pictures from one of our uh, like programs, and you can see on the top right hand corner, this is a workshop that we're running to improve the capacity of optometrists to perform objective refractions. And below that, you can see me teaching how to actually determine astigmatism correction. And the one on the left is a professor from Deakin University teaching the students how to detect an eye turn. The most recent program that we also undertook was a Train the Trainer program, where we identified highly performing optometrists and taught them how to teach optometry skills. And this was, I guess, our attempt also to make this program more sustainable. Now we have contact with the trained trainers so that they can ask us, when they have when they need advice, or want to run their own workshops, how they would go about doing that. We recognized from early on the importance of evaluation in this program. Throughout the program, we conducted questionnaires with the optometrists who were being trained regarding their confidence and skill level of using optometry techniques, as well as managing and undertaking outreach. And we've been sort of continuously doing that before and after each program. And we are currently analyzing the data, which we haven't published yet. But what we did find is that there was an overall increase or improvement in the confidence of optometrists in performing techniques, such as to correct refractive error. There was also, in the last 5 years, increase in outreach activities that have been planned by the hospital. We have also advocated with senior management to establish like a dedicated room to practice skills for optometrists, so that they can also practice the more advanced testing, like pediatric testing. The main challenges, I guess, were that not all optometrists necessarily wanted to be upskilled. They already felt they were, being paid, they were doing what they were getting paid for, and they didn't really have any motivation to improve. And ophthalmologists were also often not trusting optometrist refractions, even especially when there were high prescriptions or complex prescriptions. And this was again acting as a deterrent for optometrists to do their best. The ASHA eyecare program is a grassroots movement, which is in a way really great because it gives us the opportunity to directly respond to the needs and tailor the program accordingly. And the great thing is that it's quite transparent. There isn't a middleman in the charity, and all the funds are used for delivering equipment for the program. But because of that transparent nature, our projects are completely dependent on volunteers self-funding their trips. And this really does threaten long-term sustainability of the program. And ideas to make it sustainable, have been, applying for grants and also exploring avenues for e-learning. So in terms of future directions in eye health generally, the release of the World Report on Vision was really an important progress in assessing eye care and demands for the future. The WHO is now working on developing a package of eye care interventions called the IPEC, which is the provision of integrated people-centered eye care. And this is going to be a really great sort of guidance for how low and middle income countries can actually solve eye care needs. Additionally, WHO is advocating for universal health coverage index to track, in terms of eye care, to track met and unmet need by calculating effective coverage of refractive error as well as cataract surgery to help collect the right kind of data. And this is really critical as the change in these units used to measure eye care, and it sort of changes the way we can actually respond to eye care needs. In terms of policy measures, the Commonwealth Heads of Government meeting in 2018 has committed to the improvement of access and quality of eye care and the elimination of trachoma by 2020. These policy measures at the international level help to hold national governments in check about their progress towards targets. Similarly, there's a World Health Assembly committed to universal eye health, and this is also committed to universal health coverage. And one of those things, like I mentioned, eye care is really inevitably involved in that. The Lancet Commission has also announced a commission on eye health, which is fundamental in fueling the right research needed in eye care today, such as the global burden, the economic impacts, and things like that, which we spoke about. Other than the policy and national commitments by governments, at a more operational level, I believe the key to meeting the challenges in eye care also include improving training of health professionals in eye care and strengthening triage mechanisms. I also believe in the importance of integration of eye care into health systems and strengthening information processes to enable evidence-based policy decision-making. And that way, ministries of health then have the right power to make decisions about national planning. So thank you, everyone. For me, I guess is a really great opportunity to bring eye care into the global development sphere and to showcase why vision is so important for development. And I hope I've convinced you. Hopefully this fuels cross-disciplinary collaborations, which is something I strongly believe in thanks to my involvement in LIDC, because LIDC do this really well. I'd love to reach out to those working in international development and listening today, for feedback or suggestions about the work that I do. I'd also love to hear from people who are doing similar projects and would like to collaborate. And of course, if I can be of any advice and help to those starting a new social enterprise or a charity, please get in touch if you have any questions. Thank you again.